just want us to start with the presentation. Brian, if you can move forward with the next slide. Session facilitates cross-country peer-to-peer learning and is based on knowledge sharing amongst clinicians. Initially started focusing on non-communicable diseases, but then branched out towards many other practices and areas to discuss. The idea is sharing best practices through the use of Zoom calls, with Kenya and Nigeria acting as initial hubs, with the plan to scale across different countries in Africa. In Nigeria, we have MDOC, one of the social enterprises, have Jacaranda Maternity, as well as the Chronic Drugs Medical Scheme, otherwise known as CDMS. Next slide, Brian. So Project TeCLA has a hub and spoke model where the 3 social enterprises act as hubs for the time being. We've recruited over 100 spokes across both Nigeria and Kenya, and you can see some of the names listed in this slide. Next slide, Brian. We have collated a whole bunch of hub experts that contribute towards these discussions. And these are a few of them, as are in the next slide after this. Brian, could you move to the next one? Thank you. And then the next one. Great. Just a note to everybody that Project TeCLA leverages on the ECHO model. We collect registration, participation, questions and answers, chat comments, and poll responses for our programs. Your individual data will be kept confidential and handled by authorized personnel. This data may be used for reports, maps, communications, surveys, quality assurance, evaluation, research, and to inform new initiatives. Most importantly, this session will be recorded, and for those who are inclined, we will be sharing a PDF version of the slides after the session. Next slide, please. Participation tips and a bit of housekeeping. Please have your camera on so that we can see your lovely faces, and hopefully you can see ours. The facilitator, that is myself and the team, will unmute you when you need to speak. By all means, use the raise hand feature in the Zoom when you wish to speak, and use the chat function for any questions in relating to the topic at hand. Should you have any tech support problems, we have both Brian and Mercy's phone numbers listed over here, so please write them down in case you need to WhatsApp them with any sort of questions or issues, and they'll be happy to help. Next slide, please. This is the agenda for today. So we've started a little bit late, but this is part of the welcome introductions and guidelines. We'll make an introduction to the TeCLA social enterprises before launching into a pre-quiz and poll about the topic. Following that, we'll have the didactic on the topic managing pre-eclampsia in a cost-constrained setting, followed by a Q&A discussion by my fellow co-facilitator, who's well inclined to be able to facilitate this conversation much more than myself. We'll then have a case presentation, following which we'll have a further Q&A discussion, and then we'll have a post-quiz to see how much everybody has learned. Don't worry, you're not being grilled about anything. There's no prizes or penalties at the end of it. So please feel free to participate as much as possible in the post-quiz. Thank you. And then the next slide. Great. So moving on, this is an introduction into the social enterprises. Wish to introduce our social enterprise, which is Jacaranda Maternity. We are a chain of maternity hospitals in Kenya with a mission to transform maternal healthcare in East Africa with high quality, low cost, and respectful maternity services. Our vision is to create the largest chain of hospitals in East Africa that offers high quality maternal care as its core service at affordable prices to our clients. I'll now hand over to the CEO of CDMS, Sam Magutu.
Thank you, Savan. Good afternoon, everybody, and nice to have you here for this session. My name is Sam Magutu. I'm the CEO of CDMS. CDMS, we operate from Nairobi, Kenya, and we are in this program in joint partnership with the Rural Private Hospitals Association of Kenya, RUFA. Our mission is the usage of digital solutions to improve health outcomes in low-income populations. And we have two programs. One is an e-commerce platform that enables affordability and access to medication through group procurement. And our other program is this Tele-education of healthcare workers. This is a program that we've been running in partnership with Jacaranda and MDOC. So welcome.
Thanks, Sam. Now moving over to MDOC, either Neka, who I thought was online, or Adora, please.
Hello, can you hear me?
Yes,
hello?
Yes,
okay, perfect. Okay, hello everyone. Thank you so much, Savan. It's such a pleasure to be with you all today. I'm Neka Mobison. I'm co-founder and CEO of MDOC. MDOC is a digital health social enterprise that leverages technology, behavioral science, quality improvement methodologies, and data to provide virtual self-care support to people living with chronic health needs such as diabetes, hypertension, cancer, obesity, overweight, and coexisting mental health conditions, as well as maternal health needs as well. We are primarily focused in Nigeria. We're headquartered in Lagos, and we use a 4-pillar approach, which you see here on the slide. The first, through our omni-channel digital platform, we connect people living with chronic and regular health needs with virtual coaches who provide self-care support. So we are here for people that 99% of the time they're out of a healthcare facility, and therefore we see ourselves as complementing the existing healthcare system, complementing what you all do. And we also have Navi Health, which is our geocoded directory of healthcare services, facilities, and providers to help people navigate where to go for quality care. And the third piece is the reality is we've learned that in our society, we still have a lot to do in terms of digital literacy. And so we've set up in-person nudge hubs where people can track their metrics and speak with a coach in person. And then the fourth and really critical piece, which is why we're here today, is tele-education, leveraging ECHO, the ECHO model, to support providers, healthcare providers around boosting knowledge and capacity in chronic disease management and other areas as well. It's a real pleasure to be with you all today. MDOC has been leveraging the ECHO model since 2016 to really catalyze improvement in health knowledge across providers across Africa. And really excited to be here with the Jacaranda Maternity and CDMS team, along with Making More Health, to really drive and transform the narrative for healthcare in Africa. So thank you all.
Thanks, Neka, and so nice to see your face after a long time. We'll now launch into the pre-quiz, and this is of course about preeclampsia in a cost-constrained setting. And Brian, if you could upload the quiz questions, you'll as guests, you'll find that these questions will pop up on your screen, whether you're using a mobile phone or your laptop. So just bear with us as we upload them. So for those who are joining us, there are no points, there are no penalties. There might be some prizes for the pre-quiz and the post-quiz. So please feel free to look at your screens and answer. There's 6 questions that are available. And I can see that, you know, there's a few people who are participating. So please go ahead. I can see we're warming up. Just under 15% of people have participated. Really good going. Please continue. It'd be great to see more people participating. We'll give it a few more minutes just to allow people to read through and answer. And for those of you who haven't done so already, please do introduce yourselves on the chat function. It'd be really nice to know who you are and which company or organization you're from, so that we and also if you can have your cameras on if internet permits, it would be nice to see all your faces. You all are doing really, really well. I can see almost 50% of people have participated, so great going. I'm sure we can do better. Let's see how many more we can get on this quiz. I can see many more people submitting, which is great. We have just 1 more minute left, so put your answers in as quickly as possible. We'll have a chance to review them later on. Great. I think with that we'll end the the pre-quiz. Brian, could we end the poll? Super. Oh, I see the poll is inactive. Okay, I think we are done. Thank you for whoever switched the poll off. I think we can move on to the next slide. Thank you. So it gives me great pleasure to introduce to you the speaker for the didactic, Dr. Sarah Krantz, who is the consultant obstetrician, gynecologist, and clinical director at Jacaranda Maternity. By way of further information, she completed her education at the George Washington University with a degree in political science with a focus on health policy. She worked in Rwanda in health systems consulting prior to returning to the US to pursue her doctorate of medicine. She completed her specialty training in obstetrics and gynecology in Vanderbilt Medical Center, after which she practiced in the US in a variety of clinical settings. She's currently the clinical director at Jacaranda Maternity in Nairobi, Kenya. So Dr. Sarah, over to you. It's really nice to have you here.
Hello all, thank you so much for having me tonight. Can you all see my video? It seems like it's gone off all of a sudden. Let me try it. There we are. Okay, I'm not sure what that was, but good. Must have just timed out. So thank you so much, Savan, for the introduction. So I've been asked to speak tonight to you about the management of preeclampsia. And so I prepared a presentation that's going to focus a lot on preeclampsia, the diagnosis of preeclampsia, and the management, as well as the further discussion about the hypertensive disorders of pregnancy that puts preeclampsia into a context. And so we can start with the first slide. So hypertensive disorders of pregnancy, they affect 2 to 8% of pregnancies globally. And in Africa, these diseases contribute to about 9% of maternal mortalities. That maternal mortality percentage varies across the world, depending on which country, which region you're looking at. And that probably has to do with maternal age distribution and the proportion of nulliparous patients in a population at any given time. The hypertensive spectrum diseases are a significant driver for neonatal morbidity and mortality, and this is mostly due to the effects of prematurity, which is a direct result of these diseases. And care for these diseases is a significant driver for costs in the medical system. And again, a lot of those costs are from premature births. Next, please. So I wanted to start with the clinical definition of preeclampsia, and this is a mouthful, but stick with me. Preeclampsia is a multi-system progressive disorder characterized by the new onset of hypertension and proteinuria, or the new onset of hypertension and significant end organ dysfunction with or without proteinuria in the last half of pregnancy or postpartum. So what on earth does that mean? Let's start by putting it in context. So preeclampsia is one of the diseases in the spectrum known as the hypertensive disorders of pregnancy. This ranges from gestational hypertension to preeclampsia, preeclampsia with severe features, which is a worsening of that disease. You can have chronic hypertension or hypertension outside of pregnancy. You can have chronic hypertension with then superimposed preeclampsia, which could be non-severe and severe. You can have just seizures of the hypertensive disorders. So let's get started with talking about each of these because it's going to help us understand how to diagnose and how to manage. Next slide. So first, there are many short and long-term sequelae of preeclampsia to both mother and fetus. For women who develop this disease, they can have strokes, placental abruption, acute kidney injury. They can have end organ dysfunction like liver failure, pulmonary edema. It can lead to seizures. They can present with thrombocytopenia or low platelets, which then puts them at significant risk for bleeding. The fetus can also be affected. So you can have growth restrictions, so small fetuses, oligohydramnios, which means low amniotic fluid. And then there are the risks of prematurity, which come from delivering early. And those are, we're probably all very familiar with those by now, but they're significant to baby and they're very costly to care for. And then there's also, back one slide, please, the future risks to moms. So there's the risk of recurrence in a future pregnancy, and there's also a long-term increased risk of heart disease and kidney disease in these patients. Next, please. Next slide, please. So what can we do about this? So first and foremost, we can recognize the signs and symptoms. If we don't know what's happening, we can't diagnose it, we can't treat it, we can't take care of our moms. So create an efficient diagnosis, that's also really important. And then we need to do the right management for the right patient. Next. So when we talk about diagnostic criteria, this is obviously a problem that affects women internationally, but internationally we have different boards and bodies and colleges that all discuss preeclampsia a little bit differently. Some of the nomenclature has changed over time. Some of you might remember when it was called toxemia of pregnancy. Some of you might remember pregnancy-induced hypertension or PIH, and these have gone out of style. But even though there are variations, we've all kind of moved to a similar principle of how to recognize and manage it. And that's what I'm going to focus on, with an emphasis on what the WHO recommends. Next slide. So let's start with chronic hypertension. So this is high blood pressure that's diagnosed before 20 weeks of pregnancy, or at least 12 weeks after delivery. And so it's considered pre-existing, but not related to the pregnancy. The criteria for blood pressure would be anything greater than or equal to 140/90. And ideally, this is 2 different blood pressure readings taken 4 hours apart. It doesn't have to be on the same day. If they come in 2 different days and they have these 2 readings, they meet that criteria. Next slide, please. So gestational hypertension, what is that? Well, it's very similar to chronic hypertension in the level that creates the diagnosis, which is 140/90. However, it's recognized after 20 weeks of gestation, and in someone who previously had normal blood pressures. Unfortunately, for some women, they haven't ever presented to care before 20 weeks of pregnancy. And so sometimes we notice the high blood pressure and we say, well, we have to call it gestational because we don't have any other information. But sometimes, obviously, it could represent chronic hypertension. And so, of course, to be just gestational hypertension, they have to have no other signs of preeclampsia, which is what that no proteinuria and severe features refers to. Next slide. So how do we diagnose preeclampsia? So this would be any blood pressure 140/90 or greater, but less than 160/110. That'll come into play in a second. Diagnosed after 20 weeks, so sort of meeting those same criteria as gestational hypertension, but also we add proteinuria, and that means protein in the urine. I listed here all the ways you can diagnose protein in the urine. In the US, for example, we mostly rely on the protein to creatinine ratio. But here in Kenya, and probably in a lot of your centers, we mostly do the urine dipsticks. And so that would be 2+ protein on the urine dipstick. So if you happen to have someone who has elevated blood pressure and does not have protein in the urine, then if they have any of the following that I've listed there, then they also would qualify as preeclamptic. So that would be a low platelet, an elevated creatinine, elevated LFTs, pulmonary edema, a headache, that won't go away, or visual symptoms. But when we talk about all those more severe symptoms, I want you to keep that in your mind. Focus for preeclampsia mainly on the high blood pressure and protein. Next slide, please. So the reason I wanted you to keep that a little bit separate is because there's a worsening of this condition, and that's preeclampsia with severe features. It used to be that we'd talk about preeclampsia as mild, moderate, and severe, and we've really moved away from that. And now we talk about mainly as preeclampsia and preeclampsia with severe features. And so to have severe features, you can have any of the following, okay? Like we talked about before, low platelets, that would be under 100,000, impaired liver function, or right upper quadrant pain that usually is due to swelling of the liver capsule. You can have renal insufficiency, so your creatinine is climbing or it's above 1.1 in a pregnant woman, or doubling from their early pregnancy levels. Evidence of pulmonary edema or persistent neurologic signs. So that would be a headache that doesn't go away with rest, hydration, paracetamol, or blurry vision, seeing spots, seeing flashes. And so the other criteria that's really important is the severe range pressures. And so any blood pressure that's greater than or equal to 160/110 is considered a severe range blood pressure. If a woman presents with any of these findings and a high blood pressure like that, that's a big deal. That's severe preeclampsia. If a woman presents and she has none of these signs below, like the low platelets, the abnormal labs, but she has persistent blood pressures in the 160s/110s and nothing else, no protein in her urine, you can actually meet the diagnosis of preeclampsia with severe features based on blood pressure criteria. That is assumed to be severe preeclampsia unless proven otherwise. Next slide, please. So what is chronic hypertension with superimposed preeclampsia? Well, we talked about chronic hypertension, which is pre-existing high blood pressures. It can be very difficult to diagnose preeclampsia in these patients because some of these patients, from having long-term high blood pressure, may already have renal insufficiency, or creatinine may start out high, and they also may have protein in their urine at the beginning of pregnancy. And so it's a little bit difficult to piece this out, but if we see as we move further into pregnancy that their blood pressure suddenly becomes uncontrolled despite previous control, or their protein in the urine significantly increases, then we make the diagnosis of superimposed preeclampsia. If you add any of the severe range signs or blood pressures to that diagnosis, it becomes chronic hypertension with superimposed severe preeclampsia. And just as a comment on that, what we do know about this particular scenario is that women who have superimposed preeclampsia actually do worse than any of the other groups. So it's something to really be careful about and knowledgeable about. Next, please. So eclampsia, I just wanted to touch on this very briefly. This is sort of towards the end of the spectrum of the hypertensive disorders. It's the place we never want to get, and it's where severe preeclampsia or potentially unrecognized severe preeclampsia progresses into a maternal seizure. So this would be a grand mal seizure in the absence of any other explanation of a seizure, such as a pre-existing seizure disorder like epilepsy. Next slide, please. So I did want to talk very briefly also about HELP, because this is another offshoot of the spectrum and it's very dangerous. And so it's worth mentioning. So if we ever encounter it, we can recognize it and act. So HELP actually describes exactly what it is, which is hemolysis or breakdown of red blood cells, elevated liver enzymes, and low platelets. So like I said, this is likely a progression, although not all patients who have HELP will have proteinuria. So it can be a bit tricky to make the diagnosis. The main symptoms that people come in with when they have HELP are headache, nausea, vomiting, and abdominal pain. Abdominal pain being one of the most common. And again, this is likely from swelling in the liver capsule that causes that right upper quadrant pain. And so the reason I wanted to really stress that is because any of these symptoms could seem like a normal thing that a normal person could experience, right? You ate something bad, you have nausea, vomiting. You overdid it one day and you didn't drink enough water, you have a headache. Your belly hurts. Again, any number of things could cause that. But when someone approaches term pregnancy, all of these symptoms should be considered warning signs and they should be investigated. So like I said, new onset of nausea, vomiting, or abdominal pain at term, look into it. And keep in mind for these patients, even though this is an offshoot of the spectrum of hypertensive disorders, about 12 to 18% of these patients will have normal blood pressures. So they're not going to trigger a closer look from their blood pressure screen in clinic when they come in. Next, please. So what are the risk factors for preeclampsia? There's some on here that seem pretty reasonable and something we'd expect, and there are some that are surprising. So I want to highlight a few. One, twins is a risk factor. Twins are have risks for a lot of things. They're a high risk pregnancy, but this is also one of them. So it's something we need to be conscious of when we have multiples present for care. Nulliparity is another one that I want to really focus on because there's so many women, right? Every woman has to have their first baby. And so being pregnant for the first time is actually a risk factor. So we need to look at those patients a little closer. The other risk of nulliparity is this is their first time. If we don't tell them to be careful or to look out for something, they're not going to know because they haven't ever taken this ride before. So nulliparity is just one of those things I want us to kind of click in and remember. Having preeclampsia previously is absolutely a risk factor. Chronic hypertension, as we've discussed. Pre-gestational diabetes and gestational diabetes are both risk factors. Thrombophilias, autoimmune disorders, also those ones make a little bit more sense. But one that I also want us to flag is obesity. So BMI over 30. Older moms, so maternal age over 35 years, and anyone who has participated in assisted reproductive technology. So if you happen to be in a community where they have IVF, those women are at risk for developing preeclampsia. But one thing that's really important to remember is, statistically speaking, most cases of preeclampsia do occur in healthy nulliparous patients. Next, please. So can we do anything to improve pregnancy outcomes in this setting? Absolutely, we can. And that's because poorly controlled blood pressure in pregnancy puts both mom and the fetus at risk. We'll talk about that a little bit more. Next, please. So what are some of those risks? Well, if you have high blood pressure in pregnancy, basically you don't create a very nice placenta. And so you can have placental dysfunction, especially as you reach term and when you might get into labor and that whole question. What we sometimes see is that the placenta doesn't function as well as we hope it will. It doesn't perfuse the baby as well as we hope it will. Another thing is Iugr, which means a small baby. So again, the blood flow to the baby isn't as good. They don't grow as well. Very high blood pressures can put moms at risk at stroke. And that's the main reason that we treat blood pressures. And this is one of the things to note. I remember in training, a lot of us, that we would get asked this question. So does controlling someone's blood pressure decrease the risk of developing preeclampsia? It seems like it should. That kind of would make sense. And the answer is no, it doesn't. The only role of antihypertensives in controlling blood pressure in pregnancy is to keep mom's blood pressure out of the stroke range, so she doesn't have the effects of having too high blood pressure. And then, of course, as we've talked about, if you have very poorly controlled blood pressures, the likelihood that you'll be delivered early is much greater. Next, please. Oops, I cut out for just a second. Sorry about that. Okay, so for screening, so what can we do for our patients when they're coming in for antenatal care to kind of look out for this disease and to do what we can for patients to prevent it? Well, the first is get a good history. As we saw in some of those risk factor lists, having a prior history of preeclampsia puts you at risk. You know, a lot of things that medical conditions, diabetes, autoimmune conditions, these all put you at risk. And so we really need to obtain that from our patients. And probably a lot of you have experience with this where they come in with minimal medical records. And so a lot of what you have is just from talking to them. And so you really need to draw some of that history out if you can. So blood pressure screening at every appointment, this is so important. And it's important to get accurate readings. So that means both feet on the floor, the patient resting for 5 minutes before you take it. And so good, accurate blood pressure readings at every appointment. So if you have someone that you're looking at and you're saying, you know, they're high risk or their blood pressure was a little borderline last time, have a really low threshold to bring them back sooner, to come back for a blood pressure check. Don't let them go out and not come back for a month when you were thinking, you know, this person could be developing something here. And then same thing goes for when you're in labor and postpartum. We should be watching people's blood pressure. You can absolutely develop preeclampsia or severe preeclampsia during labor and the postpartum period, even up to 6 weeks. So not letting our patients, oh, well, they're in the hospital, so they're fine. They look fine, they're fine. We need to still monitor these things. And then screening for symptoms of preeclampsia, that is a big one. We need to actively ask patients, are you experiencing any of these symptoms? And then the number one thing, the reason I have this bolded is patient education. And that's because we are not with patients all the time. We're not monitoring them all the time. The person that is monitoring for symptoms closest is the patient themselves. And so when they're at home, they need to be looking out for certain things. And then about that. Okay, next slide, please. Thank you. So what are the warning signs? This is actually a patient education handout for women to learn more about preeclampsia and what they should be looking out for at home. And so there's the headache that doesn't go away. They're seeing spots or blurry vision. When people notice sudden swelling in their hands or face, we don't say feet because all pregnant women end up with swelling in the feet. So that's not a great sign. If they have shortness of breath, that could represent pulmonary edema. If they have pain in the upper abdomen or shoulder, that could be referred pain from swelling of the liver capsule. Sudden weight gain, again, that's third spacing fluid in the body, and a mom might notice that at home. And then nausea and vomiting in the second half of pregnancy. Again, it needs to be investigated. And these are things that women might brush under the rug otherwise, because they're things that happen outside of pregnancy, but inside of pregnancy, they have a totally different significance. Next slide, please. So I did want to focus on the WHO recommendations, and that's because there is such variation in practice and in the specific guidelines. And so I wanted to tell you what kind of a global entity's consensus is. And this is basically the recommendations based on literature review, where they said, okay, based on the strength of this evidence, this is the strength of our recommendations. And these are the most strongly recommended things. So the first one is a low dose aspirin. So that might be known as baby aspirin to you colloquially. The WHO says 75 milligrams. In the US, we say 81 milligrams, same thing, it's the baby aspirin. And that is recommended for prevention of preeclampsia in women who are at high risk of developing it. The WHO feels strongly that women with severe hypertension should have their blood pressures controlled with anti-hypertensive medications. Similarly, they believe that for women with severe preeclampsia and eclampsia, that magnesium sulfate is the preferred medication to prevent and treat seizures versus other anticonvulsants or anti-seizure medications. They also support IV or intramuscular magnesium sulfate, depending on which resources you have available, what your clinic has, and whether the patient has an IV at the time of an eclamptic seizure, for example. They also have a strong recommendation that if someone develops severe preeclampsia, that if they are not yet viable, or they won't be viable, which means about 24 weeks within one, or by the way, 24 weeks is the standard when you have the best technology possible. Viability is really dependent on which technology you have to support a preterm infant. And so your line of viability may be very, very different in your community or at your biggest hospital. And so if you're 1 to 2 weeks before that line of viability, then it's actually recommended that the baby be delivered, even if it's not compatible with life. And that's to protect the maternal life. Next slide, please. Another recommendation is if women have severe preeclampsia at term, early delivery is recommended. And that is to avoid worsening of the condition that puts mom and baby's life at risk. Women who have been treated with anti-hypertensive medications to control their blood pressure during their prenatal care should continue those postpartum. And if someone develops severe hypertension postpartum, they should also have those blood pressures treated with medication. And then this is the last thing that could be significant in your community. If there is low dietary calcium intake, calcium supplementation is recommended to help prevent preeclampsia. Next, please. So I also wanted to add the don'ts from the WHO. And what this is some treatments that have been investigated in the past or even used in the past, but have been not shown to be effective in research. So they have very weak or no support in the scientific literature. And so they're now not recommended at all. And the one I want to really draw your attention to is Bedrest. Bedrest used to be very popular for a whole, spectrum of illnesses and complications of pregnancy, and it's really gone out of style. And the reason is because one, it wasn't shown to be effective. And two, it puts our patients who are pregnant at risk of blood clots, since pregnancy is a hypercoagulable event. And so that's what they found. And so Bedrest is not recommended except for very rare circumstances in conditions that we're not at all talking about tonight. So definitely not for preeclampsia. Salt restriction also hasn't been shown to be effective. Neither has vitamin D, C, or E supplementation, diuretics, or steroids to manage HELP. Next slide. So what do we do for our antenatal care? Again, harping on this, but blood pressure monitoring. Every visit, whenever a patient has complaints, it's one of the first things we should really look to in pregnancy. If someone does have a history of hypertension, it's really great to get a baseline kidney function, so a serum creatinine. And that's going to help us first identify whether maybe they do have a chronic problem or something that needs treatment or more surveillance. It's also going to help us see a change as we get later in pregnancy if they do start to develop higher blood pressures. And this also goes for protein in the urine. Historically, we've said we should do a 24-hour urine protein collection if someone has chronic hypertension or we have concern, or for example, prior preeclampsia, something that we think they're very high risk and we want to know what their baseline is. It's very difficult and costly to collect that. So most people end up doing a urine dip, particularly sort of in a lower resource setting. So that's going to be more likely. Aspirin, the WHO recommends it. It's something that we can do to prevent preeclampsia. It's one of the only things, in fact. And so for women who are at high risk, the recommendation is to start it at 12 weeks, or if they present after 12 weeks, start it as soon as possible and continue it all the way through delivery. And that is a baby aspirin. And it's very much considered well tolerated. Some women can get an upset stomach. We recommend they take it with a meal. And generally it's quite well tolerated in the baby form. And then urine protein dip. This is something I mentioned because it's common practice in healthcare settings that when people come in for prenatal care, they automatically get their urine dipped for glucose and protein. There is literature out of the US that you don't have to do this at every visit. You can follow symptoms and then test. That was my practice previously in the States. However, you should really dictate this by what your clinic protocols are, what makes more sense for your patient flow, and to not miss anything. So if dipping every time routinely makes sense for your healthcare setting, do that for sure. Next slide, please. So I did want to drill in a little more to the aspirin recommendations, because since this is one of the only things we can do to prevent, I think that there are a lot of patients, especially in lower resource settings, that we're probably missing for this very simple and cheap intervention. And so I wanted to go through this in a little bit of detail. So women who are at high risk of developing preeclampsia, we have the list in the dark blue at the top. These are women who the recommendation is that they definitely start aspirin. And so I wanted to go through this a little bit. Having a history of preeclampsia is one of them. Having twins or a multi-fetal gestation, twins, triplets. Having chronic hypertension, having diabetes, having any pre-existing renal disease, and having autoimmune disease. These are considered the highest risk conditions, and so they absolutely should be on aspirin. I do want to flag the type 1 and type 2 diabetes. What you might notice is gestational diabetes is not on here as one of the high risks. But as we get to the moderate risk, what you'll see is a couple of the moderate risk factors are also risk factors for gestational diabetes. So I think if you have a gestational diabetic patient, you should really think to yourself, hey, do they meet this criteria that I should be considering aspirin? So let's talk a little bit about the moderate factors. Basically in this guideline, if you have one or more of these, then you should consider aspirin therapy. So sorry, I said that wrong, not one or more than one. So 2 or more. And so, we have a baby. So for the moderate risk factor group, again, I want to flag nulliparity, because what it means is for any of your patients who are in their first pregnancy, if they have any one of the next risk factors, then they should be considered for aspirin therapy. And so that includes obesity with a BMI over 30, a family history of preeclampsia, usually in a first degree relative like a mother or sister. Socio-demographic characteristics is a little bit to translate. This is from research and guidelines out of the US. And so it's a bit difficult to translate into your setting. But what I would say is if you see a high prevalence of preeclampsia in your community, maybe consider your demographic as a risk factor. Age 35 and older, so our older moms, and then also personal history factors, like if they've had a really small baby before, if they've had a prior adverse pregnancy outcome, or if there's a long inter-pregnancy interval, like 10 years, that's something to consider as a contributing risk factor. And so if you're a mom who's had a prior uncomplicated pregnancy, born at term, no issues, that's not someone who needs to be on aspirin. Next slide. So is there a cure for the hypertensive spectrum disorders? There is, and that is to deliver the baby and get that placenta out. And the reason is we do think that these diseases probably originate in some sort of factor that comes from the placenta. And we know that they're a direct result of pregnancy. And so resolving that pregnancy is really the way to treat this. And so when do we deliver? Well, it depends. It depends on quite a few things, and we'll talk about that now. So for gestational hypertension, if someone has been diagnosed with this, then we should be watching their blood pressures very carefully throughout their pregnancy, because they are at risk for escalating into preeclampsia or severe preeclampsia. If you can see them weekly as they get further into their pregnancy, that's better, because we can keep track of their blood pressures. We can remind them of the symptoms to watch out for at home, and we can do a urine dip to see if they develop proteinuria and are evolving into preeclampsia. And so for delivery timing, well, if they develop severe range pressures, but they don't have proteinuria, then we should get them delivered, because that's sort of just, they're climbing that pathway to a worse disease. And so the recommendation is actually to deliver them at 37 weeks if they're having these uncontrolled pressures. If it's earlier than that, earlier than 37, and they're having escalation in their disease process, then you need to really start looking for a facility that's able to deliver them. And so transferring them somewhere that's capable of delivering a preterm baby. And so however, for gestational hypertension, you can have people who they meet the diagnosis, but in general, their blood pressures are okay. They're not even on medication. They're just sort of stable, maybe a little borderline, but nothing, no symptoms. You can consider, based on your clinical judgment, on whether you should deliver them between 37 and 39 weeks, but you really shouldn't go past 39. And that's because that's when they're at the highest risk of escalating into preeclampsia. Next, please. All right, so how do we manage preeclampsia? Universally, the recommendation is deliver them at term. That's 37 weeks. A lot of people think, oh my goodness, we have preeclampsia, we got to get them delivered immediately, let's go to the theater. But that's actually not the case. Research has shown that if you get them delivered in a timely way, you don't let them get induced for 3-4 days in the hospital. If you can kind of move them along in induction, a vaginal delivery is perfectly safe and not contraindicated. We've also seen some people think, okay, if we induce a patient this early, then we increase the risk of C-section, but actually delivering them early decreases the risk of C-section, because it's progression into preeclampsia, severe preeclampsia, or even eclampsia, which is what pushes us emergently to do an operative delivery, when if we'd induced them, they might have successfully had a vaginal delivery. And because of this, it also decreases the cost to the healthcare system. So management, preeclampsia with severe features. If I can focus on one thing on this slide, it's going to be starting magnesium. And the reason we start magnesium sulfate, which we give as first a bolus and then a continuous infusion, is because it prevents seizures. So it prevents that escalation into eclampsia. And if they come in their term and they have preeclampsia with severe features, you don't need to think twice about it, deliver them. Okay. Maybe with antihypertensives, but you don't need to keep dosing. They're relatively stable, even though they meet that diagnosis. You can also consider a vaginal delivery. However, in our healthcare settings, if you don't have an imminent delivery, you don't see yourself getting there quickly, then that's someone you can consider proceeding with a C-section. And so here we are, persistent severe range blood pressures. This means someone who comes in and you're continuously dosing them with antihypertensives, or if you don't have those IV antihypertensives, maybe the immediate release nifedipine, and you need to consistently try to control their blood pressures to keep them out of the severe range. That's someone you need to get delivered. They're very sick and they could easily progress. And then similarly, if you're monitoring someone with severe preeclampsia, trying to have a vaginal delivery, but you notice that you repeat labs, their platelets are dropping, you're concerned that health could be evolving, you need to proceed with a C-section. Next slide. So let's talk about what we do after birth. So we need to keep watching blood pressures. Someone who has gestational hypertension, chronic hypertension, or even just regular preeclampsia with non-severe preeclampsia, this is someone who's still at risk of progressing into severe preeclampsia or eclampsia in the days after delivery. And so for any of these women, if magnesium was already started, it should be continued for 24 hours postpartum. And that's because that 24-hour period is the highest risk period for having a seizure. And if they meet the criteria for a new diagnosis of preeclampsia with severe features, then MAG needs to be started then and continued for 24 hours. And as the WHO emphasized, we need to keep treating their blood pressures, keep them in a safe range. And if they're on blood pressure medication, they do need to return to clinic within a couple of days of discharge so we can do a blood pressure check and titrate the medication as needed. Because what we see is once that placenta is out, sometimes their blood pressures resolve very quickly. And if we have them on potentially even multiple antihypertensives, they can drop their pressures at home. So, and then the last thing is that I already kind of emphasized this, but it's worth saying again, they can develop preeclampsia with severe features or eclampsia in the postpartum period, even weeks after delivery. And we've seen this where we readmit people, 3 or 4 weeks after delivery because they have classic signs and symptoms. Next slide, please. So I did want to touch on cost a little bit. In general, when we have a low resource setting or a cost limited setting, the best way to combat that is with high education. And that's because we can prevent a lot of the escalation of this disease by recognizing it quickly, managing it efficiently and appropriately. However, our toolbox for managing this disease happens to also be very affordable. And so we do have the costs in USD, and that's because we have multiple countries participating in this call. So I'm sorry if these costs don't resonate with you. But what I wanted to really emphasize is that the most important interventions here are very affordable. So baby aspirin, very affordable, 27 US cents for a month supply. Magnesium, which is what we would treat anyone with severe preeclampsia, is less than $1 for the dose that we'd put in the normal saline bag. And then the anti-hypertensive medications, the oral medications are very affordable. Obviously, the IV medication is quite expensive, but in a lot of settings, especially if you don't even have the capacity to do a quick IV, there are oral options that are very affordable. So I just wanted to touch on this to kind of let you know what the toolbox is and what the WHO toolbox for this condition is. And then also really emphasize the fact that the backbone of your management and your diagnosis is going to be blood pressure readings, and those are free. If you have a cuff, it's just the effort of your clinic staff to take those blood pressures, to take them frequently, to take them accurately. Next slide, please. So I did want to do a summary because I know I gave a lot of information and there were a lot of words, and it's worth a recap. So first of all, let's talk about preeclampsia. The quick and dirty is blood pressures 140/90 and protein in the urine, which is a 2+ on the urine dipstick, or blood pressures that are elevated and one of the other signs, low platelets, high creatinine, high liver function tests, pulmonary edema, a persistent headache, or visual symptoms. That meets the diagnosis for preeclampsia right off the bat. If you diagnose preeclampsia during their antenatal care before their 34 weeks, that's a patient who's high risk. That's a patient who needs to be transferred. They need to be somewhere where a hospital can watch them closely and where they can deliver them if needed. Because if you have preeclampsia before 34 weeks, there's a very high likelihood that you're going to be delivered before 37 weeks. And so they need to be in the right care setting for the baby. If you're between 34 and 37 weeks, there is room to monitor blood pressures closely. That means once or twice a week, having them come in, taking a blood pressure, and ideally also doing a set of labs to see if they're developing worsening preeclampsia, if their creatinine's going up, if their platelets are going down. Because if you have any worsening and they flip into the severe preeclampsia, we move towards delivery. And so if they're preterm and there's a risk they could progress, you also need to already think, where am I going to send them? How far away is that? What are the logistics of getting this patient to the right place to deliver their preterm baby? And simplest thing, if they have preeclampsia and they've reached term at 37 weeks, deliver them, get them delivered. Next. So let's talk about preeclampsia with severe features. So that's the prior slide's definition and adding any of these severe range features, either severe range blood pressures, low platelets, less than 100,000, elevated liver function tests or pain in the right upper quadrant, increasing creatinine, so renal dysfunction, pulmonary edema, the headaches, or the vision changes. And so the number one thing you do when someone comes to you with severe preeclampsia is you start that magnesium sulfate and you stabilize their blood pressures. Okay, if they're in the severe range, then the order would be stabilize the blood pressures, get them out of the stroke range, and then start magnesium. And once you've done those things, you say, okay, are they preterm? If they're preterm, you leave that magnesium hanging and you get them to a facility where they can be delivered safely for preterm care. So if that's your facility, great. If you need to send them, then you need to be making arrangements or looking into that. If they have severe preeclampsia, so preeclampsia with any of these features, severe range blood pressures, and you're at a facility that you can deliver a term infant, do it as soon as possible. It is possible if they have all the stable blood pressures, they had transient severe range, but now it's okay. Their platelets aren't low. You know, there are things that we don't have signs of worsening, then you can consider a vaginal delivery. A lot of these patients, though, especially if they've had a prior C-section, you don't even have to think about it. You just go to a repeat C-section. Next slide, please. So to summarize, what can we do? The first thing, and everyone can do this, all you need is a pen, take a good history. Talk to them. We all learn this in our medical training, whichever level of clinician you are. This was the first lesson I'm sure you learned, which was take a good history, because it's really going to help guide your patient. It's going to help you classify them at high risk. It's going to help you offer them the only intervention we have, which is aspirin in the antenatal period. And it's going to help you watch them closer as they approach term. So if anyone has abnormal blood pressures or they complain of the warning signs that we talked about, look into this. Don't ignore it. Don't brush it off. Look into it. And if they're at term, deliver them. Things only get worse from there when you're talking about the spectrum of disease. So we like to get ahead of it. We like to deliver them and have a safe mom, healthy baby before they have a chance to deliver any of those dangerous or worse symptoms. Next slide. Okay, these are my references. You can go next. So thank you. Salvan, are you jumping back in or?
I am. Great.
Okay.
Thank you, Dr. Sarah. This has been amazing. This has been really insightful and fascinating, especially for me from a non-clinical perspective. There has been a whole bunch of questions, which is great to see from everybody. I'm going to hand over to my colleague, Dr. Momani Mokaya, who's also from Jacaranda Maternity, to take over and kind of ask the questions and facilitate some sort of question and answer session that he and Dr. Sarah can go through. So over to you, Dr. Momani.
All right, thank you, and welcome everybody to this presentation. I hope you guys have all benefited and learned a lot from this bread and butter topic in obstetrics. Essentially, especially coming from Africa, if you're in the field of maternity care, one of the things that you must be very familiar with is hypertensive spectrum of disorders in pregnancy, of which pre-eclampsia and severe preeclampsia will form a majority of the presentations. So very bread and butter stuff, I think very informative. And I can take some questions. I can see some people had posted some questions during the presentation. I can throw them out there and we can discuss them. So the first question I saw is from Julius, and he's asking, what are the common practices that can help reduce the risk of recurrence of, let's say, someone has been diagnosed with pre-eclampsia? What can they do to reduce the risk of recurrence?
So
I think, yeah.
Oh, go ahead. I was just going to say, unfortunately, right now, one of the only things that we have that reduces the risk of recurrence would be aspirin therapy. And so to summarize that, because I see someone else ask this as well, ideally, we started at 12 weeks. That's a baby aspirin, so 75 or 81 milligrams, whatever you have locally available, starting at 12 weeks and continuing daily all the way through delivery. And that's the only intervention at this point that we have that we know reduces the risk of developing preeclampsia.
Sure, yes. So aspirin, like you've been told, has been shown to reduce the onset. So if we start the aspirin early, remember we were told that preeclampsia develops in the second half of pregnancy, from 20 weeks onwards. So you want to start the aspirin way before then, because by the time the symptoms show, the disease process has already established. So that is why the rationale of starting it at 12 weeks comes into play. And a lot of those women will not end up developing preeclampsia later on if you start it early. And as you've been told, it goes all the way up to delivery. And then someone else is asking, what happens to the next pregnancy and what education should we give the mothers? So regarding the future pregnancies, if they've had preeclampsia before.
Yep. So I think it's really important that these moms know that they are at risk for developing preeclampsia before. We should be checking their creatinine and their urine protein at the beginning of pregnancy to see if there's any proteinuria or renal dysfunction that they're coming into pregnancy with. And then also we need to be checking their blood pressures, ideally present early so we can check them before 20 weeks to see actually, did you actually have pre-existing hypertension or chronic hypertension? And we just don't know because a lot of women of reproductive age just don't go to the doctor except for their pregnancy care because they're otherwise young and healthy. And so those are the things that we really need to be telling moms when they come into the next pregnancy. Similarly, they need to be aware that this is if they develop preeclampsia or if they have chronic hypertension, they could grow a small baby and that could put them at risk for preterm delivery. So they just need to be mentally prepared that having preeclampsia before does make you a higher risk pregnancy. And so you don't want moms to think, well, that was then, but this is now and everything's fine, right? They need to be watching their symptoms at home. They need to be on high alert for developing any of the warning signs.
Sure. That's exactly correct. So if they get the preeclampsia as, if you get it once, you have a risk of getting it again. Of course, we know the highest risk is the first pregnancy, but then they must be careful. They must come to the clinic early as soon as they notice they're pregnant again, so that the BPs can be checked early. If they're chronic hypertensives, they're diagnosed early. So, so that's just, I think that question has been answered sufficiently. Someone else is asking, I think it's Alexandra, why are we saying that a salt restriction does not play a significant role in managing preeclampsia? Can patients or clients go ahead and take salty foods? That's the question being asked.
So the interesting thing about preeclampsia is even though it can cause high blood pressure, and that's usually the first sign of it, it's actually a function of the hormones being released by the placenta that cause it. So it's not the classic, causes of chronic hypertension that happen in other people. And salt restriction, by the way, is also controversial in the management of pre-existing hypertension, of chronic hypertension. So that's part of it. Basically, if your kidneys are functioning normally, your body should be able to modulate your blood pressure by excreting or retaining fluid. And that's just how the kidneys work and how they interact with salt. So yes, you can transiently increase your blood pressure by taking in a large salt load. However, this doesn't contribute to a worsening of the preeclampsia spectrum. And so that's why it's not an effective intervention for preventing preeclampsia or preventing the progression of preeclampsia. The problem is the placenta. So that's got to come out. It doesn't really matter. Obviously, I wouldn't say go eat fried chicken every night with French fries with extra salt, because that could put them into the stroke range pressure, right? If they already have high blood pressure and then take a massive salt load. So I wouldn't encourage salt intake, but a moderate salt intake doesn't cause worsening preeclampsia.
Yes. So I think it's counterintuitive when you say salt restriction doesn't work, because most people would think, but research has shown, because all this information is based on evidence, isn't it? So research has shown that putting on a no salt diet doesn't make a big difference. However, like someone had asked, they are not allowed, they're not given a free pass to take as much salt as possible, because they can transiently increase the BPs, and you only need to get a stroke once. So even if no salt has been shown not to make a difference, they're not encouraged to go crazy with the salt. And someone else is asking, what is the dose for the magnesium sulfate infusion? What's the dose when we're giving this infusion? Someone wants to know, is there a specific dose that is given, or does it differ from hospital to hospital?
It often does differ based on your protocols. The common one that we hear about is 4 milligrams, a loading dose, and then 2 milligram continuous infusion. But you should look at your clinic, what your own protocols are, because they can vary. One commonly accepted intervention, for example, of an eclamptic seizure is to give magnesium intramuscularly, because often they may not have an IV. It can happen out of nowhere. They can come in from the street already seizing. And so you can actually give a total of 10 milligrams of magnesium IM. You give 5 milligrams in each buttock. And so you just do IM 5 milligrams, and that's the recommended dosage for an eclamptic seizure.
Good, good, good. Yes, and I'm encouraging anybody who has any other question to please maybe raise the hand and ask the question so that we can get everybody on the same page. Let's not leave any questions unanswered. So as you've heard, there's different protocols for administering magnesium sulfate, usually region dependent and protocol dependent. I can also ask another question. When we're giving the magnesium sulfate, is there anything to look out for as we give it? Is there a monitoring, or do we just give it and, and that's the end of the story?
That is a very good question. So a couple of things to be mindful of is there is something called magnesium toxicity. And that is when the serum level of magnesium reaches a level that it starts to depress some of the normal functions of living, breathing, or if really severe, your heart rate, your mental status. And so if you, the very first thing that goes when you have magnesium levels rising a little too high is reflexes. And so what you might notice when you check someone for clonus, which is for the reflex in their foot, or you check their peripheral reflexes, either their kneecap or their brachial reflex, you might notice diminishing reflexes. And so pre-eclampsia, actually, people usually have very excitable reflexes. And so we usually call them 1, 2, or 3 plus, depending on how kind of excitable their nervous system is. And so what you might see is they came in with 2 plus or 3 plus in their patella reflex, and then suddenly we're not getting any reflexes anymore. That would be the first sign of magnesium toxicity, and that's actually a reason to pause the magnesium. If you have the capacity to test for magnesium levels, for the serum levels, you can do that. The only problem is your normal thresholds that are basically to look at people's electrolytes and what a normal non-pregnant person's magnesium might be are going to be incorrect, because it's going to show as elevated, but we want it to be elevated. We want their serum level to be between 6 and 8. Sorry, that's in US units. I'm not 100% sure of the European unit on that, but we want it to be at a higher level, but there are thresholds of levels in the US system. Again, it would be like 12 to 20 that you start getting into the danger zone and can lead to cardiac arrest. And so that's one thing. If you are going to use magnesium in your facility, I highly recommend you look up what your capacity is to monitor either magnesium levels or to train your staff on how to recognize magnesium toxicity. The other thing is magnesium is cleared through the kidneys, through the renal system. So if you have someone who has renal impairment or even renal failure, then it's a closed system. And so if you give someone magnesium and you keep a continuous flow of magnesium, that level is just going to go up and up and up, and it's not going to be cleared. And so it's really important, if you have someone who's in renal failure or has renal impairment, that you can bolus that magnesium, but then you need to be really carefully monitoring for their symptoms of magnesium toxicity. You need to have close attention to that from the nursing staff. And if you have the capacity to monitor their magnesium levels, then you should do that. If you have someone who needs magnesium and who's in kidney failure, that is also someone you should really be considering transferring to a higher level of care. So I'm really glad you asked that question, because these are really important issues to think about.
Very, very important. Yes. So the most important things when you're giving magnesium, look for the reflexes to avoid toxicity. Make sure there's urine output, because it has to be cleared. If the patient's not passing urine, they're not clearing the magnesium, you're piling up the dose. So if there's no other question, we can move on to the case presentation. I'm sure people might have questions coming up later, we can still have another opportunity to address any questions. So I think I can hand it over to Dr. Daniel Okech to go through the case presentation of a patient who presented with this diagnosis that we're discussing. Over to you, Dr. Okech.
Thank you, Doc.
Welcome.
I'll do a case presentation on preeclampsia. I'll start with the data. Patient's name was SE, 33 years old, a resident from Ngong, was admitted on the 11th of August. She came with having amenorrhea for 8 months. Next. So her complaints are headache and blurring of vision, a sharp epigastric pain for 3 days. She was at 34 weeks of gestation, 3 days. Antenatal history, first trimester visit. She was a gravida 2, para 1, LMP of 17th, EDD of 23rd. She had started her NC clinic at a private facility in Ngong. She was started on iron and folic. There's no history of severe vomiting or any other significant illness in the first trimester. Second trimester, quickening at 5th month. She was given a TT. High BP was noted at this point, 150/96. She was admitted to the ward and initiated on Aldomet 500 milligrams QID and nifedipine 20 milligrams BD. After the BPs was stabilized, she was discharged home on the medication and advised to check her BPs routinely in the nearest health facility. She was also informed on danger signs of preeclampsia. There was no further visit to the NC in the second trimester noted. Third trimester, this when she came to us at 34 weeks of gestation with high BPs of 174/100. A urine, there was a proteinuria of 1. Fetal heart rate was at 134 beats per minute. There was obvious history of headache, global in nature, with associated visual disturbances. There was this sharp epigastric pain. There's no jaundice, no pallor on examination. There's no urine, reduced urine output, no seizures noted. There's no history of vaginal bleeding. So a past obstetric history, there's a previous history of CS 3 years ago, which was complicated with preeclampsia. So this was our second event of preeclampsia. She delivered a cesarean section at 35 weeks of gestation. The baby is healthy, 2.5 kg, alive and well. On examination during this index admission, weight was 65, height 150, BMI of 28. She was a febrile, not pale, not jaundice, not cyanosed. There was obvious bilateral pedal edema, neck veins were not engorged. Her pulse rate was at 110. BP was high at 176/110. There was no any vaginal bleeding. Arrest system was okay. CVS was okay as well. Next. Our inspection, abdomen was distended, umbilicus was inverted. She was at around 32 weeks of gestation by fundal height examination. Fetal heart rate was noted at 130 beats per minute. So our provisional diagnosis was at 4 years old, para 1, gravida 2, at 34 weeks of gestation with preeclampsia with severe features in view of the high admission blood pressure. So the plan was to monitor her blood pressure. We started her on magnesium sulfate, loading dose of 6 grams. Then antihypertensives were initiated. In view of the high diastolic pressure, we started her on IV labetalol infusion. Then urinalysis and dexamethasone, because she came at 4 weeks of gestation. So we had to give dexamethasone 6 milligrams IM to help with lung maturity. The same day around 3, her BPs were still high despite the high IV antihypertensives. Urinalysis result, we had proteinuria of 3. She had papilloedema on fundoscopy, and there was now reported reduced fetal movement. And we did non-stress test, CTG. It was at category 3. So we then made plan to take her for cesarean section in view of the uncontrolled blood pressures despite the anti-hypertensive medications. So investigations that were done full hemogram, HB was 11, platelets was okay at 120. RBS was normal at 8.9, urea was okay, uric acid, creatinine were fine. Actually, there's nothing unremarkable. COVID test was negative as well. So the plan was to prepare for emergency CS. As I said earlier, we secured IV line, preloaded her, monitored fetal heart rate as we are waiting the CS. And next. So the outcome was a live female infant, 1.9 kg, with a score of 9, 10, 10. So after delivery, we still had to continue with magnesium sulfate 24 hours post the cesarean section. She continued her anti-hypertensive medication, though we stopped Aldomet in view of the possibility of postpartum depression. So right now the patient is okay, she's doing well. The baby is fine. She completed the medications. So yeah, so she's now on oral antihypertensive medications, labetalol and nifedipine. Yeah, that's all.
Okay.
Yeah.
Thank you, Brian. That was a good presentation, Dr. Oket. So I think we've seen how typically a patient will present with preeclampsia. You know, they say patients do not read books. So they may not always present exactly how, you know, has been described, but, you know, there's a little bit of variations, and someone has to take those variations into account in how to manage this patient. So this is one of those examples of how a patient can present. Any questions that we can take? I think someone has asked if there's any contraindications to giving magnesium sulfate. So that's along the line on the magnesium sulfate.
That is a great question. And the number one contraindication that we learn, you know, in obstetrics is myasthenia gravis. So that's something that you probably have never seen, or it's very rare. It's an issue with skeletal muscles, and that's because it can affect muscle function and can cause cardiac arrest. And so it is absolutely contraindicated for patients with myasthenia gravis. However, there are not really other contraindications other than if someone's showing signs of back toxicity, then you stop it, things like that. But even kidney failure, straight kidney failure, where they're not working at all, is not a contraindication. It just means you have to dose it as a bolus and monitor very carefully. And so, yeah, that's the contraindication that's most well known.
Sure. So myasthenia gravis is a definite no-no. So there's really not much that can prevent you from giving a patient magnesium sulfate. So that's to say most women with preeclampsia should be able to get magnesium sulfate. A caution, however, has been said if someone has heart block, for example. Remember we said magnesium sulfate can slow down the heart, can slow down breathing. So if they have other serious comorbidities, heart block, severe pulmonary edema, maybe you want to go slower on the dose, but it's not contraindicated. You just have to be aware to maybe give a lower dose. Somebody else, I think, asked a question. Let me see if I can see it. The role of hydrolysis in the management of postpartum eclampsia.
Yeah, absolutely. So IV hydrolysis can be used. Usually we prefer IV medications when someone has severe range blood pressures, and that's because they have the fastest onset to bring down blood pressures to get them out of the stroke range. So if that happens postpartum, you can absolutely use IV hydrolysis. You can use IV labetalol if their heart rate is stable and in a good place. You can also use PO medication. So it just really depends on what their clinical status is at whichever time.
Sure. Great. Is there any other burning question from the audience? We can take a few more questions.
Dr. Momani.
That's a good
Sorry?
question. I see the question about Aldomet. Aldomet is the only category A antihypertensive that we have. And what that means is that it was studied in pregnancy and was found to be safe in pregnancy. However, what we know from using it for a long time versus using other agents such as nifedipine, labetalol, hydralazine, what we know is Aldomet doesn't work great, and it doesn't work for all women. And so what you've seen, like in my training, we didn't use it at all. It was kind of considered old fashioned. It's still out there because it's the only safe in pregnancy medication, but we know from use, but not research, that labetalol, hydralazine, and nifedipine are all safe in pregnancy. And so they're just generally much more effective. And so they're preferred agents these days.
Yes, that's true. Aldomet is the only one that was tested in pregnancy and found to be safe. However, if you can remember, if the rest of you guys who are following the presentation, if you can go back to the costing, if you looked at the medications for management of preeclampsia, most of them are affordable. However, in most developing countries, Kenya included, one of the cheapest are calcium channel blockers. So you find that's a first line medicine nowadays, calcium, because they're very affordable, widely available, and they control the blood pressures much better than Aldomet. Aldomet, doesn't control it that great. However, it was tested and found to be effective. The rest are not shown to be harmful to the fetus. So I think in future, we may also reclassify the other medications to category A, the cheapest being calcium channel blockers. So you find as well as the other ones, but if you're looking at cost, the cheapest are the calcium channel blockers. Any other question? Sorry?
I was just going to say the only other thing to mention about, the category A, B, C medications,
Yes.
Studying pregnant women is very difficult.
Sure.
In a lot of research, the ethics boards and everything, pregnancy is its own category that you need special sort of approval and hoops that you jump through to study. And so it makes it very costly to do studies on medications in a pregnant population unless that medication is designed for pregnancy. So that's already their customer pool. And so what you'll see is things that we know are safe in pregnancy will never get category A classification because they'll never do the right study to apply for it to kind of show that it is safe or prove that it is safe. And so that's one of the limitations across the board in pregnancy care, is that pregnant women are their own class and they're very difficult to study.
Correct. However, we do know that the other drugs work great, and that's why we are using them and recommending them. So another question is coming from Elizabeth, and she's asking, probably this might be the last, I don't know if there's another question, but I've seen it as the last one. A large number of women in Africa and other developing countries are under traditional birth attendants. So what would be the advice on educating these traditional birth attendants of the challenges of preeclampsia and eclampsia so that referrals can be done in a timely manner?
Yeah, that's a really good question. I think the biggest thing is being educated on the warning signs. So the same way that we had that graphic of things that patients should look out for, all of your birth attendants, when they're doing care in the antenatal period, they should be aware of those signs and symptoms so that they can tell their patients at every visit, this is what you look out for. Or if someone comes complaining of those, they can recognize it immediately and potentially call in help or refer to a facility that's more equipped to do diagnosis, treatment, or an early delivery if needed. And so it's really all about education. If you don't know the signs and symptoms and you don't recognize them, there's no chance that you'll get the right diagnosis and efficient treatment.
Sure, very important. And also, if a woman has had preeclampsia before, she ideally should not be under the care of a traditional birth attendant. They should, I know because of resources, maybe there's no clinic available, but as much as possible, they should at least be sent to a health center, even if it's a small one, that is able to at least record the blood pressure, because at the very least, how will you diagnose preeclampsia or gestational hypertension without a blood pressure cuff monitor? So, of course, the instances where there's no health facility in sight, and that makes it a very challenging environment because these patients are probably under the mercy of nature. But the advice would be that if someone has had preeclampsia before, they're at high risk based on the risk factors, then the traditional birth attendant should have the knowledge to encourage these mothers to seek care in a more medical established facility that can pick up the preeclampsia and manage it effectively. I think I don't see any other question unless there's some new ones that have cropped up.
Yeah, I think a couple just came in.
Okay. So at what point do we discontinue? Someone is asking Goodwin. At what point do we discontinue oral antihypertensives in a woman persistently normotensive postpartum? Or do we place them on those permanently?
No, that's a great question. So what you'll see is that women's high blood pressure, if they just had gestational or preeclampsia, their blood pressures will start to soften in the postpartum period if they're on, especially if they're on an antihypertensive. And so what you want to do is you want to watch them carefully and you want to titrate down that blood pressure medication, or if it's only like the lowest dose, like you're giving someone 30 milligrams of nifedipine extended release once a day, then you would just say, you know what, stop it, and let's have you come back in a couple of days to look at your blood pressure. And so the goal is to get everyone off, and so that they're normotensive without any medications. However, if their blood pressures do not soften, if even they climb or you have to escalate, then that's someone who may need to stay on. And potentially once you reach that 6-week period, you need to start thinking maybe this person already had hypertension and maybe they need to be on long-term antihypertensives, in which case you can start to consider the class of antihypertensives which are not safe in pregnancy, like ACE inhibitors. And that's something like their general doctor might do, is say, okay, you just have chronic hypertension. What's the most effective way to control that? And we know that ACE inhibitors work really well. You absolutely can't take those in pregnancy, but now that they're not pregnant, that's an option. So it's sort of a group effort once they get into that 6 to 12 weeks postpartum period and still have high blood pressure.
Sure. So that was a great question with an informative answer. So you just keep checking the blood pressures. Usually they go down. People who just had gestational hypertension or preeclampsia, a few days or a week or two post-delivery, the blood pressure starts to come down. So you titrate the antihypertensives according to the blood pressure reduction. And then I think we can take one more question before we do the post-presentation quiz. And Goodwin asks again, on the case presentation, and Daniel, you might also be able to chip in on this one. On the case presentation, could the patient who we've just been told about possibly have had a labor induction and a vaginal delivery instead of an abdominal or a C-section?
So that is a great question, because it brings up a couple of issues that are worth reinforcing. And we can talk to Dr. Okudge too, but I wanted to just remind one thing, that the patient, I believe, and Dr. Okudge, you can correct me if I'm wrong, I believe she had a prior C-section at 35 weeks. Is that correct?
Yes, she was a previous case. She had a previous case, so induction was contraindicated for her.
Yes, so she was not in a facility that had any kind of ability, it sounds like, or practice of doing a trial of labor after C-section. So definitely not an option for that reason. But the other reason is that baby had a category 3 fetal heart rate tracing. And what that means is that baby was showing distress. And so it needed an expedited delivery. Even if you were in normal labor without preeclampsia, without anything, if you develop a category 3 tracing, you have to proceed with an emergent C-section, because that's a baby that may be on its way to having severely impaired long-term mental status versus death. And so that those are two reasons that in this particular case, vaginal delivery was not possible. However, there's one other thing I wanted to mention, and that's hypothetically, if the patient came in and maybe was a little further along, maybe it was 37 weeks and developed these symptoms, but when they treated them with the antihypertensive, their blood pressures were kind of okay, that would be a reason to proceed with vaginal delivery. You can proceed with induction. But because this patient developed severe inch pressures in spite of multiple dosing of antihypertensives, because they had a prior C-section, because the baby wasn't doing well, all those things meant that C-section was the only option.
Yes, correct. Very well answered. I hope, Goodwin, you've gotten the answer. So there was many indications to do a C-section. Induction would have probably not gone down well for that patient or the baby. So I think those are all the questions I can see. We can proceed to the post-presentation quiz. And I think we should be able to answer all the questions after the lovely presentations we've had. So can the quiz be brought up?
Just 1 minute, Dr. Mamani, we're getting that sorted out.
There's one more question about which placental features are seen on ultrasound in preeclamptic women. That is an interesting question. What you might see is a small placenta, and that's because you end up with a growth restricted fetus. So it may be small. That's not really a diagnostic feature that we use. And often a placental abruption is not necessarily an ultrasound diagnosis. Like if we're going to act on it, it's often a clinical diagnosis based on what they're experiencing, the symptoms they're complaining of, vaginal bleeding, et cetera. So it's not often that we examine the placenta closely. What we do look at an ultrasound is we look for their amniotic fluid index. And so oligohydramnios is increased in patients who have chronic hypertension and preeclampsia, small baby, so looking at the growth. And if you have the capacity, the umbilical artery Dopplers are monitored in small babies and patients with preeclampsia before term. And so these are all a little bit higher level things that you can do in a center that has the resources and the capacity to do that kind of surveillance. But those are the main ultrasound findings.
Sure.
Great. Thanks, Dr. Sarah. Thanks, Dr. Mamani. It's the quiz that is officially up now. So please, after all the learnings, take your time to answer them, and then Dr. Mamani and Dr. Sarah can have a discussion about the questions and see what the answers really are. So please go ahead. Once again, no penalties, nothing at all incurred if you get them wrong. And no prizes either, but please go ahead and do participate. Thanks. Great participation from the audience so far. Keep it up. A few more minutes to go, and then we'll go through the answers. Almost 50% participation, which is great. We'll give it 1 more minute. I repeat, 1 more minute, and then move to the answers. Ten more seconds, rush to complete, almost done, 51%. And we are done. Brian, could you please end the quiz, or Wale? Thanks. And maybe now what we can do is go through it. Dr. Momani and Dr. Sarah, over to you.
All right, good. I guess I can't remember the question, so we'll have to put them up again.
Oh, I have them. I'm happy to
Okay.
go through it if that's okay then. And then, you know, Dr. Sarah, you can answer, and Dr. Momani, you can also give your views. So number 1 was a 36-year-old uncomplicated G3P2002 at 38 weeks and 3 days presents. Her BP is 150/92. She denies any complaints. Her urine protein dip is negative. An ultrasound was normal, cephalic. A repeat BP 4 hours later is 142/86. What is her diagnosis? The options were pre-eclampsia, chronic hypertension, gestational hypertension, or pre-eclampsia with severe features. And the answer is? You're on
Dr.
mute,
Sarah,
Sarah.
you want to go for it?
Sorry, the answer is yeah, gestational hypertension. So you guys got it. So yeah, she had blood pressures over 140/90, but less than 160/110. She did not have protein in her urine. She was asymptomatic, and so no signs of preeclampsia. So it's just term and elevated blood pressures, no other signs of preeclampsia, gestational hypertension.
Sure. The only other thing it might be is unless she was chronic hypertensive and nobody ever knew, and she just, not like Dr. Sarah said before, women don't usually go routinely to check their blood pressures. So unless she was having chronic hypertension and now just during pregnancy, is when they found the BPs to be high, but that's not likely to be the case because at 38 weeks, we would have picked it up before. So the answer, gestational hypertension. Great.
Super. Moving on to the second question. So for the same previous patient, what is the best course of management? Four multiple choice options. The first one, discharge and a third, proceed to theater for cesarean section, or the final one, and apologies, my internet connection is unstable, admit for observation and blood pressure monitoring. Dr. Sarah?
Yeah, so this is a little bit of a tricky one. The best management is actually to admit for induction of labor. And that is because she has decently high blood pressure, right? 150/92 on arrival. She's term, she's 38 weeks and 3 days, which means that baby is well cooked. And what we know about someone who's just developed gestational hypertension after a previously uncomplicated pregnancy is that that's the beginning of that spectrum. And so that's someone who's at high risk for progressing to preeclampsia or severe preeclampsia if we leave that placenta in. And so because she has the baby's cephalic and she's had other babies before, you know, she's a good candidate for an induction anyway. And so that would actually be the safest course of action. We do not have a lot to gain from monitoring her. All we have is killing time until she develops a worse version of this disease.
Agreed. So I can see lots of people said admit for observation. Not a good idea. The baby is already ready to come out, 38 weeks. Best thing to do, deliver.
There's a phrase I like to use, which is safer out than in. And this is one of those cases, safer out than in.
Fantastic. Thank you for that. Third question, which antenatal intervention has been shown to decrease the risk of developing preeclampsia? Is it, and it's a single choice, so is it, and if forgive my complete butchering of these words, labetalol PO? Is it aspirin? Is it folic acid? Or is it magnesium?
Yeah, and they got it right. It's aspirin. I'm so glad that that's something that resonated. So aspirin's the only one on this list that will actually decrease the risk of developing preeclampsia. Labetalol was a little bit of a trick question because it feels like it should do something because it controls blood pressure. But as I mentioned in the presentation, the only thing controlling blood pressures in pregnancy does is keep you out of that severe range where you're at risk for stroke.
Great.
I take it, Dr. Momani, you agree, and that we can
yes,
move on to
yes,
number 4.
100%.
Thank you. Number 4, a 17-year-old G1 at 39 weeks and 6 days reports a headache with blurry vision and abdominal pain. She took paracetamol at home without relief. Her BP is 150/92. 15-minute repeat is 156/96. Her labs are pending. What is the best next step in management? Is it admit for observation and serial BPs? Is it give a dose of PO labetalol? Is it start magnesium sulfate IV drip, or proceed to theater for an urgency section? Dr. Sarah?
Yeah, so just to summarize the prompt, so this is a patient who's nulliparous, G1. She has a headache with blurry vision and abdominal pain. It's a headache that persisted despite taking paracetamol. And she also has elevated blood pressures. So she meets the diagnostic criteria for preeclampsia with severe features, since headache, blurry vision, and abdominal pain are all severe features, even though she doesn't have severe range blood pressures. Her labs are pending, so we don't know, does she have protein in her urine? Does she have low platelets? We don't know. And while you may say, well, we don't know if she has protein in her urine, so we don't know yet if it's preeclampsia, I would argue that with elevated blood pressures and 3 of the signs of the severe signs, that you manage as severe preeclampsia until proven otherwise. And so the best next step would be to start a magnesium sulfate drip.
Fantastic.
Correct.
Great.
Correct.
Thanks, Dr. Momani. And then, I'm glad to see that 55% of the respondents got it right. Number 5, the use of antihypertensives in pregnancy decreases the risk of which of the following? Is it obesity? Is it preeclampsia? Is it neural tube defect? Or is it stroke, Dr. Sarah?
The answer is stroke. And that was for the reason that I just mentioned. I did mention it in the presentation, but it is one of those things that you really have to internalize, because even in my training, it was like one of the trick questions that our attendings used to ask us. It feels intuitive. You keep someone's blood pressure low, you decrease the risk that they develop preeclampsia, but it is not true. Controlling someone's blood pressure with antihypertensives only keeps their blood pressure low enough that they're not in that emergency stroke risk classification. It doesn't actually prevent progression to preeclampsia, because the thing that's really putting them at risk is their placenta, and that's staying in and it's not being affected by their blood pressure control.
Yep, so that was a trick question. Most people fell for the trick. So antihypertensives will not reduce the risk of preeclampsia. Preeclampsia will only be treated by delivery. What you will reduce is the risk of the blood pressures going too high and the patient getting a stroke. So hopefully everybody now has seen through the trick and is knowledgeable a little bit more.
Great, thank you for the trick question. I was certainly stumped. Number 6, which of the following is not a risk factor for preeclampsia? Is it a prior C-section? Is it nulliparity? Is it type 2 diabetes, or is it twins? Dr.
And I'm
Sarah?
very happy that most people got this right, and it's prior C-section. So all of the others are absolutely risk factors for developing preeclampsia. So nulliparity, type 2 diabetes, and multiple gestations are all risk factors.
Yep, I agree.
Fantastic, great. And that ends the post quiz. Thank you so much. Brian, next slide. Just a brief request. This is something that we're looking to, so that brings to the end of our presentation, and I think it's really important for us to be able to be in a position to address more topics that you feel are very, very interesting and topical and you wish to kind of talk about. So please, in the chat, do let us know. Anything and everything is to be considered, and we'd be happy to kind of raise them as future TeCLA sessions. Brian, next slide. These are our social media platforms for all the social enterprises. So please do follow us, and if possible. Next slide, Brian. And I'd like to say thank you very much for coming.